Welcome to the deep dive. Today we're tackling something you might hear about, maybe linked to hotels or travel, sometimes even hospitals, Legionnaire's disease.
That's right.
We're going to pull out the really key stuff from some detailed revision notes. Think of it as the high-yield info, the essentials you need to know.
Getting straight to the point.
Exactly. What is it? How does it work? What are the red flags?
Yeah.
Getting lost in the weeds. So Legionnaire's disease, what's the absolute baseline?
Okay, so fundamentally, it's a serious lung infection, a type of pneumonia.
Right.
And it's caused by bacteria, specifically Legionella pneumophila.
Right.
The really crucial part is how you get it. It's about breathing in tiny water droplets that are contaminated with the bacteria.
Not just drinking it.
No, inhaling it. Think about the mist from, say, a big cooling tower on a building, or spray from a shower that hasn't been maintained well, maybe even the aerosols from a hot tub. If the bacteria are in that water, they can get airborne in those droplets, and you breathe them straight into your lungs. Now, there's a milder version, too, called Pontiac fever, which is more like a flu. It doesn't hit the lungs the same way.
Right.
But Legionnaire's disease itself is the severe pneumonia. The name actually comes from a big outbreak back in '76 at an American Legion convention in Philadelphia.
I remember hearing about that.
Yeah. So the key takeaway is inhalation of contaminated water aerosols. These bacteria, they love water systems, especially where the water is a bit stagnant and, crucially, lukewarm.
Lukewarm, like a specific temperature.
Yeah, the sort of danger zone is roughly between 25 and 45 degrees Celsius. That's where they thrive. So prevention really comes down to managing water systems properly, keeping them clean, and controlling those temperatures.
Gotcha. So Legionella pneumophila is the main culprit. Are there other related bacteria involved? And it sounds like these things are pretty common in water sources.
You're absolutely right. L. pneumophila causes most cases, but other Legionella species can cause illness too. And yeah, they're not exotic invaders. They're naturally found in freshwater environments like lakes and streams. The problem really arises when they get into our man-made water systems and find those ideal conditions: warm, stagnant water. Think about hot water tanks, those big cooling towers we mentioned, complex plumbing systems, and large buildings.
Hospitals, hotels.
Exactly. Those places often have the complex systems where Legionella can multiply to dangerous levels, just waiting for a chance to become aerosolized and inhaled.
Okay, so if the bacteria are present, who is actually most likely to get sick? Is it just bad luck, or some people more vulnerable?
It's definitely not just bad luck. There are clear risk factors. Advanced age is a big one. Older individuals are more susceptible.
Makes sense.
Lifestyle factors play a part too. Smoking is a major risk factor, as is excessive alcohol use. And then there's the immune system. Anyone with a weakened immune system is at higher risk.
Like from specific conditions.
Yeah, things like HIV/AIDS or people taking immunosuppression drugs, maybe after an organ transplant. Also, certain pre-existing conditions increase risk, especially chronic lung disease like COPD.
Yep.
Diabetes is another one, and end-stage chronic kidney disease. Malignancies, too, particularly lung cancer or blood cancers like leukemia or lymphoma.
Wow, quite a list.
It is.
Yeah.
And interestingly, even things like recent travel or recent surgery can make someone temporarily more vulnerable. And of course, direct exposure, people whose jobs might bring them into contact with contaminated aerosols, maybe in healthcare settings or construction, plumbing.
Right, that makes sense. So it really targets people who are already a bit vulnerable in some way.
Often, yes. It's frequently a combination of these factors.
Okay, so the bacteria get inhaled, they're in the lungs. What actually happens then? How do they cause such a severe pneumonia?
Well, this is where it gets quite clever, biologically speaking. Once those bacteria are inhaled deep into the lungs, they encounter immune cells called alveolar macrophages.
The lungs cleanup crew.
Kind of, yeah. Their job is normally to engulf and destroy invaders like bacteria. But Legionella has this sneaky trick. It actually allows itself to be engulfed by the macrophage.
Oh.
But instead of being destroyed, it multiplies inside that immune cell. It essentially hijacks the cell's machinery.
Wow. Trojan horse style.
Exactly. And this triggers a really intense inflammatory response from the body and the lungs trying to fight back. But that inflammation itself causes a lot of the lung tissue damage.
So it's the bacteria and our own response.
It's a double hit, yes. Direct damage from the bacteria multiplying, and damage from the body's inflammatory reaction. And in some severe cases, the bacteria can even escape the lungs and spread to other organs via the bloodstream.
Nasty stuff.
It really can be. And remember, they naturally live in water. The risk comes when we create environments where they thrive and then aerosolize them, cooling towers, those spa baths, misting machines you see sometimes.
Anything making a fine spray.
Precisely. And a
Yes.
really critical point here, you don't catch Legionnaire's disease from another person. It's not contagious like the flu.
That's important. So it's purely environmental exposure.
Correct. It's found worldwide, and outbreaks have often been linked to things like whirlpool spas and hot tubs in hotels or on cruise ships.
Given that it's a pneumonia, I imagine the symptoms could look like a lot of other things. How do doctors actually figure out it's Legionnaire's specifically?
That's a really good point. It is a diagnostic challenge. The symptoms, fever, cough, shortness of breath, overlap significantly with many other types of pneumonia.
Like bacterial, viral.
Yep, common bacterial pneumonias like pneumococcal pneumonia, viral pneumonias, even fungal ones in some cases. It can even, surprisingly, mimic conditions like acute heart failure or even SARS.
Really? SARS?
Yeah, the presentation can be quite varied. And because it can look like so many other things, it's often missed or diagnosed late. Some estimates suggest maybe up to 90% of cases might actually go undetected.
90%? That's huge.
It's thought to be significantly underreported. So the key message for diagnosis, especially for healthcare professionals, is to actively consider Legionnaire's disease in pretty much all patients who present with community-acquired pneumonia, especially if they have risk factors or aren't responding to standard initial antibiotics.
Right, keep it on the differential list. Let's zoom into the UK situation. Do we have a sense of how common it is here? What do the numbers look like?
Well, the official reported figures in the UK are typically estimated at around, say, 300 to 500 cases per year.
No.
But those numbers can fluctuate based on various factors: climate patterns, population density, the types of water systems in use, and importantly, how good our surveillance is, how actively we're looking for it.
And who gets it more?
There's a definite skew towards men. It seems to be about 2 to 5 times more common in men than women.
Interesting. What about outcomes?
The overall mortality rate is generally quoted around 10 to 15%, but this varies hugely with the patient. In elderly or very frail patients, it can sadly be much higher, potentially up to 80%, whereas in younger, previously healthy individuals, it might be closer to 10%.
You mentioned travel earlier.
Yes, that's a significant factor in the UK data. Somewhere between 40 and 50% of reported cases are linked to travel, often overseas.
Why overseas specifically?
It might be related to different standards or regulations for air conditioning systems, cooling towers, or hotel water systems in some destinations. And again, bearing in mind that likely underreporting.
A true number could be much higher.
Exactly. Some experts think less than 10% of actual cases get officially reported. And just to reiterate those risks in this context, older age, smoking, and a weakened immune system don't just increase the chance of getting infected, they also significantly increase the risk of a severe outcome, including death.
Is there a particular time of year it's more common?
Yes, there's a noticeable seasonal peak, usually between June and September in the UK, summer and early autumn.
Warmer weather, maybe more use of cooling systems?
That's the thinking, yes. And typically we see sporadic, isolated cases rather than large, headline-grabbing outbreaks, though those do happen occasionally.
Okay, so if someone does get it, what would they actually experience? What are the classic symptoms or signs a doctor might look for?
Well, it often starts fairly typically for pneumonia, high fever, chills, a cough, which might be dry initially but can become productive, meaning you cough up phlegm, shortness of breath, muscle aches, myalgia, headache, and just general fatigue, feeling really wiped out.
Pretty standard flu-like or pneumonia symptoms, then.
Yes, but there are some other features that can be clues. Gastrointestinal symptoms are quite common with Legionnaire's, things like nausea, vomiting, or diarrhea.
Oh, okay. That's less typical for standard pneumonia.
It can be a pointer. And then there are some more specific things clinicians look out for. The cough, as I said, often starts dry. Confusion or altered mental state can occur. And then there are lab findings like low lymphocyte counts, low sodium levels in the blood, hyponatremia, and abnormal liver function tests. About a third of patients might develop a pleural effusion fluid collecting around the lung.
You mentioned two forms earlier, Legionnaire's and Pontiac fever.
That's right. So the pneumonic form, Legionnaire's disease proper, LD, usually has an incubation period of about 2 to 10 days. Key features are that high fever, cough, difficulty breathing, dyspnoea, and often those GI symptoms.
And Pontiac.
Pontiac fever has a much shorter incubation, maybe just 1 to 2 days. It presents more like an acute flu-like illness fever, headache, muscle aches. Importantly, a cough is less common, maybe only seen in about half of Pontiac cases, and it doesn't involve pneumonia. It's generally self-limiting.
Right. And on examination, what physical signs might be present?
Fever, pyrexia, is common, and often rapid breathing, tachypnoea. And then there's a really key, almost classic sign we look for, relative bradycardia.
What's that exactly?
It means the heart rate is slower than you'd expect for the degree of fever the patient has. Normally, fever makes the heart beat faster. Finding a relatively slow pulse in someone with a high fever is a strong clue for Legionnaire's or other atypical pneumonias.
Ah, slow beat with the heat. Something to remember for exams, perhaps?
Definitely a high yield point. Doctors might also hear abnormal sounds like crackles when listening to the chest. And while rare, you could potentially find signs of pericarditis, inflammation around the heart, an enlarged liver, or that altered mental state we mentioned.
That relative bradycardia sounds like a really useful clue. So if a doctor suspects Legionnaire's, maybe because of the symptoms, the bradycardia, or risk factors, what tests are done to actually confirm it?
Okay, so investigations. A chest x-ray, or even better, a CT scan of the chest, is usually done first to look for signs of pneumonia infiltrates or consolidation in the lungs. But these aren't specific just to Legionnaire's.
So how do you nail the diagnosis?
You need specific lab tests for Legionella. The main ones are testing respiratory samples like sputum or fluid washed from the lungs and urine tests. The urinary antigen test is very common as a first-line investigation.
How does that work?
It detects parts of the Legionella bacteria antigens that are excreted in the urine. It's quick and easy, but the standard one mostly detects only the most common type, L. pneumophila serogroup 1. So a negative test doesn't completely rule it out if other types are involved.
Right. What about the respiratory samples?
Sending sputum for culture is really important. Growing the Legionella bacteria in the lab is considered the gold standard. It confirms the diagnosis definitively and allows labs to identify the exact species and serogroup, which is useful for tracking outbreaks. PCR tests on respiratory samples are also increasingly used. They detect bacterial DNA.
So multiple ways to look for it.
Yes. A confirmed case is usually defined by isolating Legionella from a culture or demonstrating what's called seroconversion, showing a significant, usually four-fold rise in antibody levels against Legionella in blood samples taken a few weeks apart, or a positive urinary antigen test alongside clinical pneumonia.
And presumptive.
A presumptive case might be based on clinical pneumonia plus just a single high antibody titer, or a positive DFA test that's direct fluorescent antibody staining on a respiratory sample. Specific criteria also exist for diagnosing hospital-acquired cases, looking at timing relative to admission and potential links to the hospital environment.
Are there other general tests that help paint the picture?
Definitely. A full blood count might show a high white cell count, sometimes with a left shift suggesting bacterial infection. Electrolytes are checked, looking especially for that low sodium hyponatremia. Kidney function tests, urea and creatinine, are important as kidney injury can occur. Liver function tests might be nonspecifically abnormal. Blood gases help assess how badly the lungs are affected.
You mentioned differentiating it from other atypical pneumonias earlier.
Right. Briefly, things like mycoplasma might show different blood count features or cold agglutinins. Chlamydophila pneumonia is usually diagnosed via serology or PCR. For Legionella, besides the specific tests, those pointers like potential clotting issues, DIC, low sodium, raised kidney markers, maybe elevated muscle enzymes, CK suggesting muscle breakdown, are all part of the pattern.
Okay, so a diagnosis is made. What's the actual treatment?
Right, management.
Right.
Patients with Legionnaires'Disease usually need to be admitted to hospital.
It's that serious.
It often is, yes. A big part of the treatment is supportive care giving oxygen if blood oxygen levels are low, providing intravenous fluids to combat dehydration, and managing fever and pain.
And antibiotics.
Absolutely crucial. Antibiotics are the mainstay of treatment. Historically, erythromycin was used, but current guidelines often favor other options. Newer macrolides like azithromycin or clarithromycin are common choices, as are fluoroquinolones like levofloxacin or ciprofloxacin. Doxycycline can also be an option.
How long is the treatment?
Typically for about 10 to 21 days. It often starts with intravenous antibiotics in hospital, potentially switching to oral tablets later on. The really critical factor for a good outcome is starting appropriate antibiotics promptly. Delay can lead to worse results.
And the public health side.
Yes, that's vital too. If a case is confirmed, public health authorities will investigate to try and find the environmental source, that cooling tower, the spa pool, whatever it might be, to prevent more people from getting infected. For severe cases, those newer macrolides or fluoroquinolones are often recommended as first-line therapy straight away.
What about the outlook for patients? What's the prognosis, and what can be done generally to prevent this?
Prognosis really depends on the severity of the illness, the patient's underlying health, and crucially, how quickly effective treatment was started. With prompt antibiotics, most people, especially those who were previously healthy, will recover fully.
But it can be fatal.
Yes, unfortunately. Severe cases can be fatal, particularly in vulnerable groups, the elderly, the immunocompromised. Factors associated with a poorer prognosis include delayed treatment, extremes of age, and those underlying conditions we talked about, like HIV, diabetes, or end-stage renal disease.
And prevention?
Prevention is really about water system management. For travel-related cases, it requires international collaboration and good surveillance networks. But fundamentally, it's about properly maintaining and regularly testing water systems, especially in places like hotels, hospitals, cruise ships, anywhere with complex systems or where vulnerable people gather. Ensuring correct water temperatures, preventing stagnation, using appropriate disinfectants, staff awareness and training are also important.
The role of hospital water seems key there.
It is. While the precise contribution to hospital-acquired infections can sometimes be debated, rigorous surveillance and maintenance of hospital water systems are considered essential preventative measures.
And if things go badly, what are the potential complications of Legionnaires'?
Well, the most serious complications relate to the lungs and the body's overall response. Respiratory failure is a major concern, sometimes requiring mechanical ventilation in an ICU.
Okay.
Septic shock can develop, where the infection triggers widespread inflammation and dangerously low blood pressure. Acute kidney injury can occur due to dehydration or shock. In the worst cases, it can lead to multi-organ dysfunction.
Any other systems affected?
Yes, neurological complications like confusion or delirium can happen, but again, prompt diagnosis, appropriate antibiotics, and good supportive care are the best ways to minimize the risk of these serious complications and improve the chances of a good recovery.
Right. So just to wrap up the key points. Legionnaire's is that serious pneumonia caused by Legionella caught from inhaling contaminated water aerosols, think cooling towers, hot tubs, complex plumbing, not person-to-person.
Correct.
Higher risk for older adults, smokers, people with weakened immune systems, or chronic illnesses. Diagnosis involves specific tests like urine antigen and culture, and watch out for that relative bradycardia, slow heart rate with fever.
That's a great summary. And prompt antibiotics are key.
Absolutely. Prevention focuses heavily on managing those water systems effectively. This has been a really helpful deep dive, especially highlighting those crucial diagnostic clues and risk factors.
Glad it was useful. Understanding these aspects, transmission, risk, diagnosis, treatment, is vital.
For more in-depth information and resources to help you succeed, do visit pastthemsra.com and freemsra.com.